Hi, my name is Alvin Wells. I'm going to talk to you today about new treatments for juvenile idiopathic arthritis. I think the first question that comes up, what does an adult rheumatologist do in talking about juvenile arthritis? Well, one of the questions we get also asked all the time, particularly with our pediatric colleague, is, what about all the therapies we have for adult patients, and can we use those drugs safely and effectively in patients with juvenile arthritis? I thought it'd be useful to take a step back and give you an idea when we talk about juvenile patients with arthritis, the criteria are completely different than we see with our adult patients. We're definitely looking at patients who are under the age of 16, and we're then of course looking for arthritis. Not only are we looking for the amount of swelling that they have, but looking for effusions, and then other things that we might see in the pediatric patients. A decreased range of motion of the joints, we look for tenderness or pain, and also increased temperature of the joints, so those joints are going to be warm. And then, of course, for the criteria for using these newer drugs, the patient will have disease for at least 6 weeks. Now, remember that with juvenile patients, they have different subclasses of arthritis, and that's usually defined based on the number of joints that are involved, but also the presence or absence of systemic symptoms. For example, those patients who have less than 5 joints involved, those are patients we call polyarticular or oligoarticular arthritis. Those that have more than 5 inflamed joints, those are polyarticular ones. And the ones we're the most concerned about are ones who have systemic onset arthritis. They can have fever, lymphadenopathy, and other features as well. Again, of course, for the criteria, not only for the research purposes, but also for using these drugs, we want to exclude other forms of childhood arthritis like the viral arthritis that some of these kids can get. This slide is an older slide, but it gives you an idea of what goes on in these patients. For example, you look at the polyarticular, and systemic onset patients, they're completely different. For example, the polyarticular patients are increased risk of developing chronic uveitis. These patients are usually going to be ANA positive. If you look on the other side, the systemic patients very rarely get uveitis, but they have other problems that goes on. These patients can be sick with fever, they can have the rash, increased swelling of their lymph nodes, and of course organomegaly of both of the liver and the spleen. So this is something to kind of keep in mind, and then the question comes up, how can we treat these patients more effectively, and are any data to support the use of newer drugs? I'll show you a snapshot of some data that was presented last year at our meetings both at ACR and EULAR that looked at the use of tocilizumab in those systemic onset patients. There are some data to show that patients with rheumatoid arthritis, they actually can see elevated levels of interleukin-6, not only in the serum, but also in the synovial fluid. So the question comes up, can we use tocilizumab in these systemic onset patients? This is a trial, a smaller trial, that looked at different dosages in patients based on their weight, either 8 milligrams per kilogram or 12 milligrams per kilogram given every 2 weeks IV. And again, the patients here that we looked at, the juvenile scores, listen to ACR JIA 30, a 30% improvement in a number of different features, plus the absence of a fever, which is really key. These patients, a mean age of 9 years, they had disease for at least 5 years, but a lot of activity. Look at the number of joints that were involved, 17 to 21 joints, and most of these patients did have a fever. The primary outcomes that we looked at is the drug effective compared to placebo infusion rather. You see 85% versus 24%. Again, a smaller trial, a 12-week trial. Now there's an open label extension that was seen after the 12 weeks to show that after 1 year, you see on the bullet points here, 52% of these patients were able to stop their steroids. If you look at the patients who went into remission, again, almost half the patients went into remission. And if you look at the bar graphs here, a significant decrease in all these systemic features. The rash, the fevers went away in a majority of these patients. And again, at ACR 70, which is close to remission, you see over almost 70% of the patients here. So again, some really encouraging data for these patients with systemic onset who for now have had a lot of other options that are involved. I want to take a stop there and have a chance to ask some questions, some interaction from the audience.
Alvin, that was really interesting new data. Can you remind me about the current or the established biologic agents? Which of those are approved for patients with JIA right now?
Artie, that's the challenge in part because, again, as you know, the numbers are larger and trying to do a randomized, double-blind, placebo-controlled trial. The TNF agents are still used. We use them all the time. Adalimumab, etanercept is out there, but also abatacept. That's one that's approved in kids, and a lot of people overlook that. Off-label, we can use things, and many of us use anakinra, so those helps out, particularly in some of the systemic onset patients. And now we might have another treatment option. There's some data out to support the use of that.
So there is a limited population of JIA to study, which is why there are probably so few drugs that are approved. But that's the same population we're going to get safety data from. So where do we get safety data from with regard to these agents in kids, and what do we know?
And that's the thing too. Again, it's not as much data that we see, particularly for the adult patients. For example, most of the data we get from our adult patients coming from these registries, mainly out of Europe and other places. So for us, for the pediatric population, it's going to be similar types of things, looking for the registries and for all long-term marketing data that we have. We know that the drugs, they can be safe. The slide that I showed you, I didn't talk about the safety issues. The really only thing that popped up, there was some cases of some mild neutropenia, but no malignancies, no other systemic infections that we're worried about. So that's one thing that we will need some more safety data from, again, in particular long-term use in these patients.
But for the children who have the oligoarticular, what used to be called oligoarticular, there was a lot, the biggest problem we always worried about was uveitis and damage to the eye. What about uveitis? Are these medications of any value?
Yeah, right now we haven't seen a whole lot of data coming out with tocilizumab. Most of the data is coming out with the use of the anti-TNF agents. Now, if you take a step back and look at animal models, you can find IL-6, you can find IL-1, you can find tumor necrosis factors that are actually in the aqueous humor from the inflamed eye. So those TNF drugs that work the best, we've seen data with infliximab, adalimumab, and also some smaller data with etanercept. If you can, from the meetings last year, most of that came out of patients who had other diseases like ankylosing spondylitis or inflammatory bowel disease. Really didn't see much data on the tocilizumab, so that's something to let to be discovered. So if I had to summarize, I think that tocilizumab is going to give us a new addition to our armamentarium in treating these patients. And mainly those sick patients who have a systemic onset, that we have the data that shows that it is efficacious. The biggest question we're going to need to see if the drug is going to be safety and looking at some long-term data over the period of time.